You started the statin. Within weeks, your legs ached, your shoulders hurt. Your doctor said it was the nocebo effect, in your head, or just part of getting older. That answer was not good enough. The science increasingly says it was not even right. There is one vitamin most cardiologists do not check before they put you on a statin. Recent research suggests it may be the missing variable in who develops muscle pain on a statin and who doesn't. In the next 18 minutes, I'll explain why statins cause muscle pain at the cellular level, which one vitamin most often fixes it, the lab test you need to ask for, and the dosing protocol that actually works. I'm Dr. Richard James. After more than 3 decades in cardiovascular medicine, I have watched thousands of patients stop their statin because of muscle pain that nobody could explain. Most of them never had to. Statins are the single most prescribed cardiovascular medication in seniors. Roughly 40% of adults over 60 take one. Somewhere between 5 and 25% of those patients report muscle pain at some point. A meaningful share of them stop the medication, against medical advice, against cardiovascular benefit, often without ever testing the variable that may have changed everything. If you stopped a statin in the last 5 years because of muscle pain, your cardiovascular risk is higher today than it would be if you had stayed on it. The decision to stop was rational at the time. The information you needed to make that decision differently was missing. Here is what the data has shown. A meta-analysis pooling multiple studies on vitamin D status and statin-associated muscle symptoms found that vitamin D deficiency was significantly more common in statin users with muscle pain than in those without. The connection has been replicated across observational cohorts and supplementation studies. The harder question isn't whether vitamin D matters. It's why it matters. And the mechanism, when you understand it, changes how this entire conversation should go. Stay with me, because this connects back to a vitamin you can measure with a $30 lab test and supplement with a $10 bottle. You were told the pain was the nocebo effect. Maybe sometimes it is. Often it is not. You were told it was just aging. Aging does not cause bilateral leg aches that started within 2 weeks of a new prescription. That is an event, not a process. You were told the absolute risk of true statin myopathy is small. That is correct. The risk of severe rhabdomyolysis is genuinely rare. But rare severe myopathy and common nuisance muscle aches are 2 completely different problems, and conflating them is exactly how the conversation gets short-circuited in a 12-minute appointment. Most cardiologists never order a vitamin D level before starting a statin. They don't because the connection wasn't widely accepted 10 years ago. The connection is much better established now. The standard hasn't caught up to the evidence. This is exactly where most people make a critical mistake. They blame the statin. They blame their age. Some of them blame themselves for being soft, for complaining, for not pushing through. The actual variable is something they could fix in 8 to 12 weeks if they knew to look for it. That is where I want this video to leave you. Not blaming anyone. Looking at the variable nobody measured. Here's where it gets really interesting. The variable nobody checked has a specific name, a specific lab test, and a specific dosing protocol. It is sitting in front of millions of statin patients waiting to be measured. To explain why vitamin D matters, I have to explain why the muscle pain happens in the first place. Most patients have never had this explained to them, and once you understand it, the rest of the video makes sense. Statins work by blocking an enzyme called HMG-CoA reductase. That enzyme is the rate-limiting step in cholesterol synthesis in your liver. Block it, and your liver makes less cholesterol. Less cholesterol in circulation means less LDL. Less LDL means less plaque. That is the cardiovascular benefit you take the statin for, and it is real. Here is what most patients never get told. The same enzyme is also a step in the synthesis of another molecule called CoQ10. CoQ10 is essential for mitochondrial energy production. Mitochondria are the tiny power plants inside every cell, and muscle cells are loaded with them. Block the enzyme. You lower cholesterol. You also lower CoQ10. CoQ10 levels in muscle tissue drop measurably in patients on statins. This has been documented in muscle biopsy studies dating back over a decade. Lower CoQ10 means the mitochondria in your muscle cells run on less fuel than they used to. The cell is not dying. It is not damaged in the structural sense. It is just running short of energy. That energy shortfall, repeated across millions of muscle cells, becomes the dull ache or the deep fatigue that sends patients back to their doctor saying, "Something isn't right." The drop is real and measurable. Studies that biopsied muscle tissue from statin patients found CoQ10 concentrations 30 to 40% lower than baseline within weeks of starting the medication. Plasma levels drop too. The body adapts to some extent over time, but the depletion is the entry point for everything else that goes wrong in the muscle. That is the first piece. Mitochondrial energy depletion in muscle. There is a second piece. Statins also disrupt calcium signaling inside muscle cells. Calcium is what tells a muscle when to contract and when to relax. Healthy calcium handling is what makes a muscle feel comfortable. Disrupted calcium handling is what makes a muscle feel cramped, twitchy, or sore, even when you haven't done anything to it. The third piece is more recent. Statins activate a protein degradation pathway called the ubiquitin proteasome system. In moderation, that pathway is normal cellular maintenance. Activated for too long in muscle tissue, it shifts the balance toward muscle protein breakdown. Add those three effects together: lower mitochondrial energy, disrupted calcium signaling, tilted protein breakdown. You have a muscle cell that is structurally fine, but biochemically stressed. That biochemical stress is what you feel as pain. This is not the nocebo effect. This is biology that has been documented in muscle biopsy studies and confirmed in cell culture work. The patients are not imagining it. So now you know why it hurts. The next question is the one that actually changes outcomes. How do you stop the mechanism? The one vitamin is vitamin D, specifically 25-hydroxyvitamin D, the form measured on standard labs. Studies have consistently found that statin users with low vitamin D are more likely to develop muscle pain than those with normal levels. The overlap is too consistent to be coincidence. It shows up in observational cohorts, in cross-sectional analyses, and in the supplementation studies that came later. The mechanism overlap is direct. Vitamin D regulates calcium signaling in muscle tissue, the same calcium signaling that statins disrupt. When vitamin D is low, calcium handling is already impaired. Add a statin on top, and the disruption compounds. Here is the part most cardiologists never act on. Restoring vitamin D to the optimal range has been shown in observational data to reverse statin intolerance in a real subset of patients. Not all patients. Some have a different reason for the pain. But a meaningful share of patients who were labeled statin intolerant turned out to be vitamin D deficient. Once their D level was repleted, they were able to tolerate the statin again. The Gluck observational data on this is striking. Patients who had stopped multiple statins because of muscle pain, then had their vitamin D measured and supplemented, were able to restart and tolerate the medication that had been intolerable before. The variable wasn't the statin. The variable was the vitamin D level the system never checked. This is not a fringe theory. This is published, replicated, and ignored by the standard pre-prescription workup, mostly because the pre-prescription workup hasn't been updated. There is a reason this matters specifically after 60. Vitamin D deficiency is the rule, not the exception in seniors. Skin synthesis of vitamin D drops sharply with age. The skin of a 70-year-old produces roughly a quarter of the vitamin D from the same sun exposure as the skin of a 20-year-old. That decline is biology. It happens whether you are health conscious or not. Add to that the fact that most seniors spend less time outside than they did decades earlier, and that sunscreen, common after a certain age, blocks the wavelength that triggers synthesis. Most adults over 60 have lower vitamin D levels than they did at 30, often without knowing it. They feel fine until they are given a medication that depends on calcium handling working correctly, and suddenly their muscles are hurting. Now, before I give you the dosing protocol, there's one question I want you to ask yourself. Are you actually deficient? The protocol depends on the answer. There are 3 other nutrients commonly recommended for statin muscle pain: CoQ10, magnesium, vitamin B12. Each one has a story, and each one has limits. Let me walk through them, because the choice between them matters. CoQ10 has the strongest mechanism case. Statins directly deplete CoQ10. Replacing it should help. The trial evidence for symptomatic benefit, however, is mixed. Some studies show modest improvement in muscle symptoms. Others show no difference compared to placebo. CoQ10 is reasonable to try. It is not the strongest evidence-based starting point. Magnesium helps general muscle cramping. Magnesium deficiency causes cramps in everyone, statin or not. If you are deficient, replacing it will help. It is not specifically connected to the statin pathway. Magnesium is good for muscle cramps in general, not for statin myalgia in particular. Vitamin B12 matters for nerve health. Some statin patients have neuropathic symptoms, tingling, burning, sharp pains, that overlap with B12 deficiency. B12 is worth checking. It is not the dominant variable for the dull bilateral muscle ache most statin users describe. Vitamin D wins on a three-part test. The cleanest evidence link to statin myalgia. The cheapest lab to measure, about $30 in the United States, often covered by insurance. The cheapest supplement on the shelf. You can begin to know within 8 weeks whether your level was the problem. This is why I lead with vitamin D. The other 3 are reasonable to add or sequence later, but D is the place to start. Before I give you the protocol you can take to your doctor on Monday, there's one thing you need to understand first. The dose depends entirely on your starting level. The most common objection I hear is from patients who say, "I tried vitamin D and it didn't help. My doctor told me my level was fine." I hear this every week. 2 distinct problems are usually hiding inside that statement. The first is what fine means on a lab report. Most labs use a deficiency cutoff of 20 or 30 nanograms per milliliters. Below that, you are flagged. Above that, you are labeled sufficient. But sufficient on a lab does not mean optimal for muscle symptom relief. The Endocrine Society's clinical guideline puts the optimal range higher, around 30 to 60 nanograms per millil, and many experts in this space target the upper half of that range for patients with active muscle complaints. A patient with a level of 28 will be told their D is sufficient. That patient is well below the range associated with muscle benefit in the supplementation studies. They were not supplemented because the system told them they didn't need to be. The second issue is duration. The muscle pain reversal in observational studies typically required 8 to 12 weeks of consistent dosing. Not 2 weeks of trying, not 1 month. The cell takes time to rebuild. Calcium signaling enzymes need to be replaced. Muscle protein turnover happens on a slow clock. If you supplemented for 3 weeks, didn't feel better and stopped, you did not run the experiment. So when I see a patient who says vitamin D didn't work, I ask 2 questions. What was your blood level when you started? What was it after 8 to 12 weeks? And were you actually consistent with the supplement during that window? Most of the time, the answer reveals the experiment was incomplete. This is not a magic bullet. Some patients on statins develop muscle pain unrelated to vitamin D status. They will not respond to repletion. The point is not that everyone who tries D will be cured. The point is that there is a measurable variable, a cheap test, and a cheap supplement, and the system has been ignoring all 3 of them for a decade. If you stopped a statin because of muscle pain and you never had your vitamin D measured, you have not finished the diagnosis. You have stopped at the symptom. The decision to be on a statin or off one is a real medical decision. It deserves to be made with the full set of information. Right now, most of the patients making that decision are doing it without one of the most important inputs. The number is a starting point. The lab is the next step. The protocol is the path. Here is exactly what I want you to do. This week, call your primary care or cardiologist's office. Ask for a 25-hydroxy vitamin D test. The lab code is 25OHD. Use that exact phrase. Insurance generally covers this lab once a year for medical reasons. Statin muscle pain is a clear medical reason. When you have the result, write the number down. If your level is below 30 nanograms per milliliter, you are deficient by every standard. If it is between 30 and 40, you are technically sufficient, but still likely below the muscle symptom optimal range. If it is 40 to 60, you are in the range associated with muscle benefit in the published data. The dosing. Standard repletion in the published literature is 1,000 to 5,000 IU of vitamin D3 per day, taken with a fat-containing meal for absorption. The exact dose depends on your starting level and your doctor's judgment. Higher starting levels of repletion are sometimes used short-term in profound deficiency. The maintenance dose for most seniors lands in the 1,000 to 2,000 IU range. Recheck the level at 8 to 12 weeks. Do not give up before then. The muscle symptom changes lag the lab number by weeks. You may see the level rise before the muscles feel better. If your level was already optimal and the muscle pain persists, you have just gathered useful information. The next conversation is about CoQ10, statin switching, every other day dosing, or considering whether the pain has a non-statin cause that was never properly evaluated. Write "checking my D" in the comments below. That single phrase tells me you've decided to ask for the lab, and it tells me what to cover next on this channel. I'm Dr. Richard James. Subscribe because next week I'm covering the common medication that quietly raises blood pressure in 1 in 5 seniors, and that almost nobody connects to their numbers. That's the video that pairs with this one. Take care of your muscles tonight. They have carried you this far.